Hi, everyone. Welcome to the fourth webinar in ICA Speaker Series, Navigating ICBPS Conversations with Experts. Today's webinar will feature Jennifer Fariello Moldwin presenting When Sex Hurts. We are so excited you are here with us today.
Thank you.
A few housekeeping items before we start. Please note that this session will be recorded. If you are on camera, your video will be included in the recording. To ask a general medical question, not personal, please use the raise hand feature in Zoom. You will be asked to unmute yourself. Please stay muted when you're not speaking. You can also ask a question using the chat feature. Jennifer will answer as many questions as she can in our hour-long webinar. Please prepare your questions to ask Jennifer immediately following her presentation. Without further ado, please welcome Jennifer Fariello Moldwin.
Thank you. Thank you so much for having me. Let me just, okay. So I am going to be talking today about when sex hurts. The focus of this lecture is primarily on female sexual pain. I'm going to touch just a tiny bit on some causes of male sexual pain. That is not my area of expertise. I'm a women's health nurse practitioner and have been treating urogenital pelvic pain conditions for about the last 21 years or so. So really, I really focus on female. With that being said, there are specialists available. There are experts in male sexual pain as well. But I don't want to ignore the fact that, yes, men do also have pain with intercourse or sex. One more disclaimer, when I use the term intercourse, sexual activity, sex, for purposes of this lecture, I'm really referring to any type of vaginal penetration, penile vaginal penetration, dilator, dildo, vaginal penetration. So I just want to make that clear that I'm just going to use those overarching terms throughout the lecture, and that's what it means. Okay, so 75% of women have pain during intercourse at some point. For some, it's temporary. However, for about up to 45% of women who report pain with vaginal penetration, it does become a long-term problem. Up to about 5% of men also report pain during intercourse. The medical term is dyspareunia, which is from the Greek, and it actually means difficulty mating. So far too many women live for years with dyspareunia instead of asking for help. Having painful intercourse is nothing to be embarrassed about. So if your clinician doesn't take your concern seriously, it's really important to find somebody who will and who will work with you to help treatment. If dyspareunia is not managed, it can result in decreased libido or interest in sex, mood changes, psychological symptoms. The effects can trickle down, and negative effects may negatively affect many aspects of your overall health. So women and men report pain in different locations. Women typically report pain with intercourse in the labia or the lips, the vestibule, which is the opening, the clitoris, deeper in the vagina, pelvis, bladder, abdomen, lower abdomen. Men typically report pain during or after intercourse in their penis, testicles, again, deeper in their pelvis, bladder, perineum, rectum, any of these areas. So there are different causes of pain, which we'll get into. These are just some prostatitis, phimosis, vaginismus, pelvic floor dysfunction, endometriosis. So causes of male sexual pain, again, I'm just going to touch on this very briefly. Different things that can cause pain with intercourse in men can be something prostatitis. It can be acute prostatitis or a chronic prostatitis, pelvic floor dysfunction, interstitial cystitis, bladder pain syndrome, phimosis, and that is tightening of the foreskin. That can be caused by different dermatological conditions, different autoimmune conditions. Sometimes when it's so tight, actually the foreskin can tear and you can have little what's called microfissures, which can be extremely painful during intercourse. Different types of infections, sexually transmitted infections, urinary tract infections, anything like that. Hernias can cause pain, especially after intercourse. Scar tissue, either from previous abdominal or hernia surgeries, anything like that. Peyronie's is curvature of the penis, which can actually cause a lot of pain. Actually, both for if they have a female partner and for them, it can cause pain. And also prolonged erection. So different medical conditions such as sickle cell anemia can cause what is called priapism, or an erection that lasts more than 4 hours. Different medications that men take, Viagra, Cialis, stuff like that can cause prolonged erections. So let's do some myths versus facts. So pain with sex is normal. That is definitely a myth. So some women may experience discomfort with their first sexual experience, but overall should not have pain routinely with vaginal penetration. How about it's all in your head? A lot of my patients come in and they say, my gynecologist told me it's all in my head and I just have to have a glass of wine, or I just need to use more lube or something like that. That's also a myth. So dyspareunia is real, and there are many causes which vary and can be physical, psychological, relational, a combination of all three. Feeling stressed, self-conscious, or afraid of intimacy can decrease libido and can cause sex to be painful. Oftentimes, dyspareunia begins as a physical problem, but also affects your mental well-being and relationships, causing stress and anxiety. Then that stress and anxiety can exacerbate physical pain. Also, patients with a history of sexual trauma or abuse can also have worsening of their dyspareunia. All right, so the pain described as burning, stabbing, cramping. Pain can occur during and or after intercourse. Pain can affect both men and women. And all of those are true. Patients, the description and location of the pain may help in the diagnosis and treatment, because patients' descriptions of pain vary. The location and timing of pain also varies among patients. So no two people really present the exact same way. So I'm gonna now talk about the different causes of dyspareunia. There are two types of dyspareunia. Entry dyspareunia is pain at the opening. This typically occurs with initial penetration, and this is right at the introitus. Deep dyspareunia is what we typically, when we ask patients, do you have pain with deeper thrusting? Is there deeper pain, like bladder pain, during intercourse? And as the name implies, this is deep pain during intercourse. So first, let's talk about some causes of entry dyspareunia. Vulvodynia, I see a lot of vulvodynia. Vulvodynia is described as burning, stinging. It can, people can say it's itching, soreness right at the opening. So at the introitus or the vestibule. Vulvodynia used to be called vulvar vestibulitis. It's also called localized provoked vestibulodynia. Any of these terms, again, I'm going to use this broad term of vulvodynia when we talk about this today. So the pain can be localized right at the opening, the introitus. It can be generalized. So the pain can actually be further out in the labia majora. It can be in the mons pubis. It can be in the perineum, down into the thighs, into the glutes. And you can have a combination or a mixed. It can be provoked. So when something hits that area, this is typically the vulvodynia that we think of with initial penetration. Something hits the opening, you get pain. Sometimes it's spontaneous. Like I have patients who they're just standing, they're teachers, they're standing at the chalkboard teaching, and they just have severe, intense burning of their vulva. So nothing really set it off at that point. Or again, a combination of both, which is a mixed. It can be constant, it can come and go. It can be primary or secondary. So primary vulvodynia is the first time anything was ever inserted into the vagina. That can be a finger, a tampon, a penis, a dildo, anything. There was pain. There was always pain. There was pain then, and there has always been pain. Secondary, women had penetration without pain for a period of time. It could be months, it could be years, and then something set off this pain cascade, and they developed pain every time something entered. It could be an infection, really bad UTI, really bad yeast infection. It could be stress. It can be hormonal changes, anything like that. Now, to be diagnosed with vulvodynia, you have to have pain greater than 3 months without another known cause. Now, that does not mean that you can't have another comorbid conditions. I have plenty of patients with vulvodynia who also have a vulvar dermatoses or who also have recurrent yeast infections. But in order for us to really diagnose a patient with vulvodynia, none of that can be active at the time. So second cause of entry dyspareunia is vulvovaginal dryness. 17% of women aged 18 to 50 and up to 56% of menopausal women complain of vulvovaginal dryness. They describe it as itching, burning, stinging irritation They can also have increased frequency and discomfort with clothing. Things that cause dryness, hormonal changes. So again, that perimenopausal period, like the 5 to 8 years before menopause, and then menopause definitely can cause dryness. After childbirth, your estrogen levels plummet. And then if you go on to breastfeed, they stay low. So a lot of women come to me after they give birth and they continue to breastfeed for the next like 3 to 4 months, and they are really dry and they really have difficulty with initial penetration. Different changes around your menstrual period, during ovulation, right just prior to getting your period, that's a time when a lot of people report discomfort and pain. Certain medications can cause dryness. Birth control pills, again, it really puts your serum estrogen level down almost at a perimenopausal state. So typically we see women that come in, young women on birth control for years, that complain they always feel dry, they really need lube, and it's really just a side effect of the birth control. Antihistamines, we use hydroxyzine a lot for the treatment of interstitial cystitis, bladder pain syndrome, which can really cause a lot of drying. Different chemotherapies can cause drying. Antidepressants, again, we use nortriptyline and amitriptyline for both vulvodynia and interstitial cystitis, which in turn, cause dry mouth, dry eyes, constipation. Guess what? It causes a dry vagina too. And also anticholinergics. So the gotta go meds, that they definitely can cause, they're a big cause of vulvovaginal dryness. Stress and anxiety, smoking, alcohol, irritants, soaps, detergents, douching, anything you put in your vagina that takes away the good bacteria that will disrupt the pH can result in more dryness. Also, lack of arousal, lack of foreplay, any of these things. Okay, so the third cause that I'm going to talk about are vulvar dermatoses. So there are different vulvar dermatoses associated with dyspareunia. 4 of the most common are lichen sclerosus, lichen planus, lichen simplex chronicus, and contact or allergic dermatitis. Lichen sclerosus, lichen planus, they are more of an autoimmune condition. They cause scarring, loss of the labia, loss of different structures. It can cause closing down of the opening of the vulva and also deeper in the vagina, lichen planus. Lichen simplex chronicus is really, the best way to describe it is more like an eczema of the vulva. So the skin is the hair-bearing areas get very, very itchy. So you scratch, the skin gets thicker. It makes it more itchy. So you scratch more, it gets thicker. It's the scratch itch cycle. And then contact allergic dermatitis, we used to tell people, even with lichen sclerosus and lichen simplex chronicus all the time, to put some Aquaphor on because, it's moisturizing. Aquaphor has lanolin in it. So some people that actually had like a contact or allergic derm from the lanolin, it was making their condition worse because they were using the Aquaphor on there. So typically people report itching, burning, soreness. Your skin is so thin that it can fissure or tear really, really easy with any type of penetration of anything. Again, the scarring to the opening in both lichen sclerosus and lichen planus. And in lichen sclerosus, a lot of women get phimosis of the clitoral hood. Just like men can get phimosis of that foreskin, the clitoral hood actually scars down onto the clitoris. And so it's impossible really to retract it. There are different degrees of phimosis, but sometimes it can really be very, very painful for women if it's rubbed or touched or anything like that. Infections and inflammation, vaginal infections, different types of STDs, gonorrhea, chlamydia, HSV, herpes, on the right at the opening, that can be a cause of entry dyspareunia. Urinary tract infections, if you're burning when you pee, your urethra is really tender, and as a penis or anything enters the vagina, it hits that urethra, it can be really, really painful. Trauma and injury, so female genital mutilation, that can cause a lot of scarring. Pelvic surgery, stuff like labiaplasty and things like that. Even when, we'll talk about it a little bit later, women have, their hymen doesn't completely break and they have to have surgery, that can cause sometimes scar tissue right at the opening. Different types of accidents, little girls have bike accidents all the time. Well, women who cycle a lot, they also have bike accidents. I actually had a patient once that fell through a deck and a wood board came and hit her into the vulva, and we had to work a long time to try to get that entry dyspareunia to settle down. Different congenital factors. Oh, here's the micro or imperforate hymen. Again, this is when the hymen does not completely break. The vaginal agenesis just means the vagina doesn't develop correctly. So then there's deep dyspareunia. So this can occur due to certain medical treatments, such as pelvic surgery. You can develop scar tissue, hysterectomy. Sometimes there's changes of anatomy, so it causes some pain. It feels different. Different types of cancer treatments, like radiation, that can cause deep pain with intercourse. Can occur due to medical conditions. So we'll look at urological first. So you have a really angry bladder, interstitial cystitis, even urinary tract infections, and that bladder, when we examine, we can actually feel sometimes if you're in a really bad flare, if it's swollen and hot and it's tender. So if a penis goes in and out during thrusting and it's hitting the posterior wall of that bladder, that is going to be the source of a lot of pain for women. Also GI, so irritable bowel, inflammatory bowel disease. Anytime the bowel's irritated, women can complain of lower abdominal pain, rectal pain. From a urogynecological perspective, some prolapse. As you can see, these are different stages. Stage 4 is the bladder is completely out. But even stage 1 and 2, if it's down a little bit, something is in there, it can actually cause some pain. GYN causes endometriosis, fibroids. Again, if the uterus is bigger and a penis or something hits it, it can cause some pain. Ovarian cysts, so you have all these little cysts on one side or the other, and you have deep penetration that can hit that ovary with those cysts. PID is pelvic inflammatory disease. Women can have an inflamed cervix with this condition. It can bleed. It can be really, really painful. Musculoskeletal, pelvic floor dysfunction, that's pretty self-explanatory. So pain with any kind of sexual activity, intercourse, penetration, there's a cycle to it. So what happens is, you've had pain for a while, that you're going to have pain anytime something is put into the vagina. So when you anticipate pain, you have fear, anxiety, and what the automatic thing to do is to clench and to tighten up because you're expecting that pain. So then when you tighten, it makes it even more painful. Sometimes penetration is completely impossible because you're so tight. Some women, through different types of, through sex therapy, different types of homework or exercises that they give, even through physical therapy, with diaphragmatic breathing, you can kind of breathe and kind of relax. But sometimes it's just so tight that the pain intensifies that reflex response and your body just automatically braces and you can't even relax your pelvic floor. And that leads eventually to avoidance of intimacy, lack of desire, lack of arousal, inability to have an orgasm. All of these things can occur. I'm going to go back to just a couple more myths versus facts. So women come in all the time and say, I'm never going to have sex again. I'm never going to enjoy sex again. That I usually say overall is a myth. So sex, with the caveat, sex may not be the spontaneous, romanticized version that you see in the movies. It might not be seamless in a field of wildflowers or on a beach somewhere, but it is possible with the correct treatment, patience, planning, and realistic expectations to have sex and enjoy it. So we'll get into a little bit more of that later. So treatment is the same for everyone. That is also a myth. So just as there are many causes and presentations of dyspareunia, there are many treatments which are individualized to each person. So really, if you go in and somebody just has this cookie cutter approach, we know that overall that probably won't work long term because, you can be somebody who's perimenopausal, plus they have IC, plus vulvodynia, plus pelvic floor dysfunction. You have to treat each of those conditions in order to decrease the dyspareunia. Treatment depends on clinicians from many disciplines working together. Obviously, this is extremely true. The treatment for dyspareunia necessitates people from urology, urogyn, GYN, GI, physical therapy, psych, sex therapy, everyone working together for the patient. So let's just talk really quickly about some treatments for dyspareunia. We always start with behavioral modifications, things that you can do on your own. just to kind of decrease irritation, inflammation. Sometimes it helps with the burning. So the first thing we always go over is genital care for your vulva, for your vulvovaginal area. One is avoid soaps, body washes, bath gels on that area. Just wash with warm water. That's all you need. I usually recommend if you want to use Dove unscented on your body or Cetaphil or something like that, but not on your vagina, just warm water. Also, some women complain that when they feel any kind of moisture, it causes more irritation. So they really rub or they use a hair dryer on their vulva to dry. Neither of those will help. Really just gently pat to dry your vulva. You want to avoid things like thongs, girdles, tight jeans, tight pantyhose. You want to let air flow. We recommend usually cotton underwear, something loose. If you're at home, no underwear. You want to wash your underwear in a hypoallergenic detergent, and don't use fabric softener or dryer sheets on your underwear. The rest of your clothes are fine, but just nothing that actually comes up against your vulva. People love they love panty liners. Everyone wears panty liners. Panty liners can be extremely irritating. There are different kinds of underwear now that, they have the leak-proof underwear. They make underwear when you have your period. I typically recommend that somebody tries that if they really are insistent that they want something every day. And sometimes that will just help to lessen some of the burning and pain. Definitely unscented pads and tampons, preferably all cotton. Always has known irritants in there. I've had patients come in with burns of the pad and the wings on their vulva. So we typically recommend just avoid always, if you're gonna use a pad or a tampon, something unscented. And again, people love baby wipes too. Baby wipes can be really irritating. They do make something called water wipes. I know they're available on Amazon. That's all it is water, and that's the better option to use. Also, you don't want to use deodorants, douches, any other vaginal cleaning product. You don't need anything in your vagina. And try to avoid over-the-counter yeast medicine. Vagisil can be really, really irritating. Again, Summer's Eve, any of the feminine washes, douching, anything like that. So what we do is we treat the underlying condition first. So if it's an infection, we give you meds to clear the infection. A hormone imbalance, depending on what it is, there are some oral things. Typically we stick with topicals. We get vulvar derm under control. And then if surgery is needed to correct something like prolapse or an imperforate hymen, vaginal stenosis, we'll refer you to a surgeon to take care of that. Then we use a lot of topical creams. Typically first line is an estradiol compound, maybe with some other things, maybe alone. It really depends on your symptoms and the history, the physical and all of that. Oral medication, suppositories, can use Valium suppositories. We use baclofen suppositories. If it's vaginal dryness, hyaluronic acid suppositories are great. In New York State, recreational cannabis is now legal. We certify people all the time for medical, but a lot of my patients say that there are suppositories that are the cannabis suppositories. They love them. They said it really helps them to relax. It really helps to decrease pain during intercourse. And again, if it's a pelvic floor thing, we do trigger point injections. Physical therapy is a mainstay treatment for dyspareunia. We usually always send people to physical therapy. There they do internal work and external. They relax those tight muscles. They do the myofascial release. Desensitization, a lot of times if it's entry dyspareunia, one of the ways that they do that, you can get like a washcloth and rub it on your vulva to start to desensitize anything that can rub up against there. Dilation therapy, if PT doesn't suggest it, I always suggest it to my patients. This is getting different size dilators and graduating up until there's no pain with use. This is not putting a dilator in and out like a thrusting motion. You put the dilator in, you let it sit there for however long. It's called containment. And what it does, it desensitizes the vulva and it stretches those superficial muscles. Again, some stretching yoga poses are great. Home exercise programs that the physical therapists give our patients, they all really, really help. A lot of patients balk at, again, when I suggest sex therapy, but it really does help. It can change a negative emotional response to sex that has built up. It can help the patient work on relationship issues that contribute to emotional pains or things that trigger physical or sexual pain. It's also an outlet to talk about what is happening and how you feel about it. It gives you a better sense of what brings you, your partner, or both physical and sexual pleasure. And they also help to broaden your concept of sex to include activities other than penetration. So to start with, if penetration is always giving you pain, they can offer suggestions of other things to do, whether it be manual stimulation or oral sex or different types of sex play. They're really good at coming up with suggestions for that. Okay, so ready to have intercourse, what do we tell people? What are some comfort measures that you can do? So before intercourse, I can't stress enough, planning is key. Communication is essential. You have to talk to your partner and tell them. Doesn't mean necessarily that you have to schedule to have sex on a certain day. It doesn't, but sometimes it does. A lot of my patients don't like this either. They're like, this is just way too much. I have to plan this. This is too much. Sex should be spontaneous. And to an extent, that's true. But when you're having pain, you have to do some of this stuff first. So what do we tell patients? To pre-medicate. So if you have bladder pain syndrome, or if you have bladder pain with intercourse, you can take a pyridium or a Urabel before. If it's more of a muscle, you can take a muscle relaxant. Patients can do oral or suppository. I typically say to use the suppository rectally if you're going to have sex. It's just less messy. That being said, I always caution patients, there's a higher absorption when used rectally. So really, you should try it first, a time when you're not going to have sex, just see how you react to it. Patients with IC, great thing to do is home bladder installations. Do an hour or two before you have sex. You can do it again afterwards if you need to. Patients with pain right at the opening or the entry dyspareunia that's burning, you can use lidocaine 5 minutes prior. You want to make sure you wipe off the excess or use condoms during intercourse. Otherwise, your partner will get numb and sex will be prolonged, which then in turn will cause more pain. Again, dilation, maybe 3 to 5 minutes prior to any type of penetration. It'll just help to stretch out and desensitize. So when that initial penetration from your partner occurs, you don't have that bracing and that clenching because you've already dilated just previously. So during intercourse, again, communication is that if something doesn't feel right, if something hurts, you need to tell your partner and make adjustments. Lube, I can't say it enough, lube, hypoallergenic, either a water-based or a silicone-based lube. Silicone-based tends to last a little longer than water-based. Water-based can get sticky and tacky and dry out a little bit. Silicone is really nice, but if you're using certain dilators or certain types of condoms or something, sometimes it's recommended not to use silicone. So you just have to be aware. Foreplay, that helps to increase arousal, helps to increase lubrication. It helps for you when you and your partner are involved in foreplay. You can say, this hurts, that hurts. It's easier to communicate. You want to make sure you focus on positive sensations during foreplay. If it starts to really hurt, start thinking more about the good sensations and then communicate. You want to limit thrusting time. This is important. This is important just not to do like marathon sessions with thrusting at first. You want to limit that to a small amount of time. So incorporate, again, the foreplay. I tell patients to try circular motion. So if they get down to the edge of the bed or wherever they are and their partner stands and can move their hips in a circle like a hula, it takes the pressure, the deeper pressure off either the uterus or the bladder or the pelvic floor muscles, and also less thrusting against the vulva. Experiment with different positions. Not everyone will have positions that work for them better than others. So some of the ones that sometimes work are reverse missionary. So when the woman is on top, you can control the depth, the depth of penetration, the angle, how long. Side lying a lot of times works for vulvodynia pelvic floor because it takes the pressure off the vulva. Patients with primarily IC pain say that this can sometimes hurt a little more. So again, it's kind of trial and error with positions. Then after intercourse, again, communication. This was good. This worked. This didn't work. You have to talk to your partner. And then apply ice. I have my patients a lot of times wet some pads and put them in the freezer. So they always have a frozen ice pad available to put on. Even get some gloves, fill it with water, tie it like a balloon. Again, put that in the freezer, have a frozen hand. rip off an ice finger, insert it after intercourse. It's like icing a sore muscle, and it just helps to decrease some of that pain if you have pain afterwards. Again, a thin coat of topical lidocaine if you need it, and you don't have to worry about wiping it off that time. You can just leave it on. If you're using any kind of topical cream to help with pain, you can use that. If you did not pre-medicate before intercourse, you can medicate afterwards, again, with the pyridium or Urabel to try to prevent an IC flare, muscle relaxants, and if you get recurrent UTIs, antibiotics. So in summary, so dyspareunia for both men and women is real. There are many different causes of dyspareunia. The biopsychosocial approach to treatment is the most effective. Realistic expectations, planning, and communication are essential for success. And finally, it's really important to find a clinician who listens and really is willing to help and work with you. And that's what I have. And then questions. All right, let me know what I'm going to do.
Okay. Hi, thank you so much, Jen. Yep, there are some questions and comments that are in our chat.
Okay.
Okay, so the first
I'm just going to go back on here. Is that all right?
Yeah, perfect.
All right.
Yeah. Okay, so the first one says, there's a comment from Jane. It says dryness can also be caused by comorbid Sjogren's.
Oh, of course. Yeah. And I think it's any of the autoimmune conditions, anything like that, of course. There are lots of things that can cause vaginal dryness.
Next question is, what about unscented flushable wipes?
Again, a lot of times they have different ingredients in there that can cause some kind of more of an irritation. So we really try to stay away from those wipes. Really, the water wipes are the best if you're going to use a water wipe. You know, I also tell my patients, which great, Amazon has little bidets that you can put on top of your toilet, and it kind of works with your toilet. You don't have to buy a whole new toilet or anything. And that helps if they're having pain afterwards, you know, just to rinse your vulva.
Okay, good. Okay, next. When treating vulvodynia with estriol, is there a risk that it might increase the neurogenic inflammation underlying some of the vulvar pain?
No, typically it decreases the pain, and it should not cause neurogenic inflammation.
Okay. Another question. I live in a tropical climate. Cotton gets wet very fast and stays wet and uncomfortable since it dries slow. Is there a vulva-friendly, fast-drying option? Nylon, etc. Thank you.
You know, that's a good question. So when we say that, you know, we recommend these things, it's kind of like people with interstitial cystitis who, if you go on the food diet, like not everything is going to bother you, but you'll find what bothers you and what doesn't bother you. Again, I think it's sometimes just trial and error. Like some patients love the wicking underwear and it doesn't bother them and actually is better for them than wearing a panty liner or wearing other things. So that might be an option for cotton underwear as one of those wicking underwears.
Great, thanks. Another question. Can you explain how you ice a pad? I missed that part. Yeah. Sorry.
Nope. You just wet it with water. Just saturate it with water, a pad, and stick it in the freezer, and you'll have a frozen pad. It works really well, and it's cheaper than buying ice packs, I think, all the time.
Wow. Thank you. Okay, the next one. Do you have patients that have severe pain all day or so after having sex and it lasts for 3 to 4 days, similar to UTI, but no infection? What is the best type of physician to address this issue?
Again, a lot of times if it feels like a UTI and it's pain for a few days, but there's no infection there, I mean, you know, mine goes to interstitial cystitis, you know, because a penis is or whatever is hitting the bladder. It could also be, you know, when your pelvic floor muscles are tight, you can also have urinary symptoms. So it's kind of like peeling an onion, and we'll treat you to see who, you know, what works best for you. What kind of clinician, you know, somebody that specializes in chronic urogenital pain syndromes. So either urogynecology, urology, something like that.
Okay, great. It looks like somebody recommended a bidet, Brondell bidet seats.
Great.
So there we have
Perfect.
recommendation. What about vaginal and perineal pain when sitting?
Again, I think that would really depend on history and exam. If you have pain with sitting, I will recommend like a pudendal neuralgia or pudendal nerve pillow with, it doesn't have like a round cutout. It has like a slit. So it takes pressure off of the vulva and the perineum. That's an option. If it's pain after intercourse and you're just really sore, that the cushion's a good thing too.
Okay. Next up, have you had good luck with compounded vulvodynia creams, amitriptyline, gabapentin, baclofen, and lidocaine?
So good results really, it's again, very individualized. So we really kind of try to figure out what is caused. Is it more nerve pain? Is it more pelvic tightness that's causing your vulvar pain? Is it hormonal? So we really try to figure that out and then prescribe the compounded cream. I mean, yes, I don't usually use all three together. I usually use either like amitriptyline baclofen or maybe gabapentin baclofen or amitriptyline gabapentin. But again, it depends on the presentation and what we think is really the cause.
Okay. Next question. If a panty liner is cotton-based, organic, and scent-free, would it be okay to use?
That would be the best one to use if you really need to use a panty liner. I try to tell my patients, please, unless you're going out somewhere, if you're afraid you're going to leak a little bit or something like that, if you're home, just don't use a panty liner. But otherwise, if you need to, that would be the best kind.
Okay. Okay, we have a person asking about if you're seeing new patients, maybe we reach out to them after because they want your contact info. Okay, any recommendations for type of overactive bladder protection, pad or depends? Likely to be less irritating.
I think poise is not so irritating. I know that in my office, because I work in urogynecology, so my colleagues all treat overactive bladder and stuff like that. We have a list of vulvar friendly pads to use for for leaking. I don't have it off the top of my head. I can always get it for you.
Okay. Great. Next question. Would using a bidet open you up to bacterial infections, or is it similar to using water to rinse off in the shower?
It is. It's like, or a peri bottle that you use. Some people fill up a little bottle with water and squirt afterwards. It's really similar to that. It should definitely not open you up to more infections. In fact, people with recurrent UTIs, we recommend that they get a bidet.
Okay. Next up, dating is hard when sex hurts. How do you suggest patients address that?
Again, communication, just so important. You really just need to be honest with your partner. So you can discuss different ways, different things to do. I just think really communication. If you're having a hard time trying to start that conversation, sometimes your clinician can help. A lot of times we'll send you to sex therapy and they are phenomenal at giving you those tools.
Okay, thank you. Next, can you have scar tissue form from lichen sclerosis in the urethra and or vagina that can permanently affect pain during urination or sex?
So lichen sclerosis can involve the urethra. In the vagina, it's not lichen sclerosis. So typically if you have scarring in the vagina, it's more of a lichen planus. And again, that's biopsied. That's how you tell the difference sometimes. But yes, it can cause scarring down and it can cause pain. It can cause inability to empty your bladder. It can cause bad flow, stuff like that.
Okay, thank you. Another person would like your contact info, so we'll address that later. Could you repeat the options to use instead of panty liners? Thank you.
Yeah, so there are different kinds of underwear now that they make that are either during your period or even for leak-proof underwear. There's also sweat wicking underwear that can sometimes help. The names I don't off the top of my head. There's a whole bunch of them though. If you just Google leak-proof underwear or menstrual underwear, it'll come up.
Great, thanks. Do sympathetic nerve blocks help vulvodynia?
Sometimes, but they typically don't last very long. So sometimes we use it just to, to help with diagnoses.
Okay. Which kind of doctor should you consult for vulvodynia when you also have IC?
Yeah, there aren't that many of us that do all of it, but there are, again, if you look in urogynecology, if you look in sometimes urology, I think you're better off with urogynecology when it comes to that, just because they have more experience with both the vulva and also the bladder.
Okay, thanks. I've tried many of these things and have come to the conclusion sex is just not worth having pain during and after for 3 to 5 days. I feel so guilty for this. Any suggestions?
That's a tough one. So, again, everything is so individualized. Communication with your partner, just to say how you're feeling. You shouldn't feel guilty if you're having pain and you don't want to have pain. Sometimes we'll send to sex therapy just to talk about these feelings that you're having. Again, if you've tried absolutely everything, sometimes you have to do other things, different types of sex play, not penetration.
Thanks. And then we have someone saying, I have pain in urethra after sex, burning in caps, and frequent need to urinate that will last a few days. I do take Uravel before. We'll try ice and ibuprofen. Any other suggestions?
You can take Uravel afterwards too. You can use a little Lidojet, which is a little, it's like a sterile lidocaine in like this little syringe, a blunt syringe. You could put right at the opening to your urethra and squirt some of that into your urethra. See if that helps.
Okay, thanks. We have another question. I've been scared to try a bladder installation because it seems like the catheter would cause more discomfort. Does that ever happen?
Sometimes, yes. A lot of times, especially, our patients with urethral pain and really bad bladder pain, we use a pediatric catheter. It is so small. It really, and, we put a ton of lidocaine in first, so you are numb when it goes in. It really shouldn't cause that much pain. You should at least try it with a tiny catheter and some lidocaine.
Okay. That looks like all of the questions in the chat. Do we have anybody else that wanted to ask anything? You can even raise your hand and ask if you want. Okay, we have Susan F.
Yes. Back in the late 1990s, I was having pain with sex, and I was turned away when I asked for help, and it was really traumatic for me. And I just wonder, is it now more open, easy to the whole topic to talk about pain with sex? Has it changed?
I think overall it has become more, it's out there everywhere. I think that women are really starting to really just take control of their sexuality and their, their pain, if they have pain, and talk about it and really just make it known. With that being said, I think it really depends on also who you see, and how they react. It's really hard. I think overall, yes, it has become more open.
Thank you. Anybody else, you can raise your hands and I can look to see if there's any other questions. In the meantime, we got a couple more comments. Somebody wrote, pediatric boy catheter works great for me.
They do. They work great. They're tiny.
Great. That's great. Somebody writes, I would recommend a book called Let Me Count the Ways for suggestions for outer course and encouragement that intercourse is not necessary for fulfilling pleasure. A very helpful concept. We have a question. Oh, we have it. Okay, Mary. Mary has her hand raised. We'll go to Mary. Mary, are you muted? I don't hear Mary, so,
I don't either.
okay. Mary, we will answer your question if we can hear you, or maybe you can type it in the chat. Okay, let me get back to the chat over here. Okay, the book. Okay, another person asked, do you recommend Therawans?
Yes, so the glass wands are they talking about that one or the big one that you use on the outside? Because there's two types of Therawand. So there are little individualized ones that are glass ones that you can use to do myofascial release, release the trigger points internally, even right around the vulvar opening. Then there's the big one that you can do for the external muscles. You kind of hold, it's like a hook, and you can put pressure on the trigger point. They're both great. Just be careful with the internal ones. Usually we have a physical therapist show the patients how to use it the first time.
Okay, I was reading down and she said internal glass.
Oh, yeah, they're great. Yeah.
Okay, and we have a bunch of comments about how helpful and great this lecture has been, and how grateful everyone is. And then we have another question. Do you recommend TENS units?
TENS units can be really helpful, especially for bladder pain afterwards. I don't have that many people that use it for vulvar pain or anything like that. But it can be helpful to decrease some bladder pain. So people with IC, BPS, TENS can be, TENS are good. I think a new study just came out showing the efficacy of TENS units.
Okay, great. Please describe the suppositories. What are they? What brand?
So which suppositories?
I don't
we use
remember.
A couple of different kinds.
Okay.
So Valium suppositories, baclofen suppositories, they come from a compounding pharmacy. They have to be prescribed, by a clinician. That is really for pelvic floor, muscle, so muscle pain. Then there are hyaluronic acid suppositories. Some of them can be prescribed, can be sent to a compounding pharmacy. There's also a brand online. I can say it, right?
I think so.
Okay. It's Reverie. It's by Bonafide. They are hyaluronic acid suppositories. You can buy those over the counter yourself. And that's really good for vaginal dryness. Then the cannabis suppositories, that is state by state. You'd have to go to a dispensary if it's legal in your area. If you have medical, you get a certificate for medical cannabis, you go to the dispensary, you just kind of find out.
Great. Thanks. Let's see. Any special advice for those with HX tamoxifen and lasting side effects and multiple pelvic surgeries?
Yeah, that can be really tough, especially with the dryness. Tamoxifen, a lot of times we will use hyaluronic acid. There's also, other types of non-hormonal topicals that you can use. There's something called Tramiel, which is really great for it helps to just get that tissue back in better condition. That being said, some oncologists are fine with just topical fingertip at the opening estradiol. So I always ask them to please check with their oncologist first before, because if we can use it, that works the best. As far as the scar tissue, that's tough.
Okay. I think you addressed both of these, but I was monitoring, so I just want to ask again. One person asked, what about CBD suppositories?
Yeah, there was one that was available, and I don't think that that's available anymore. And again, I would say Fiore. It might be Fiore. I would say you can even go to a dispensary just to get CBD. It doesn't have to be THC. You don't need a certificate or you don't need anything for that. I will find out though and see if I'll let you know if that's okay, if there's another one.
Great. So this question is, what's the name of the hyaluronic suppositories?
It's Reverie.
Okay.
REVEREE. I think it's made by Bonafide. So if you go on the Bonafide website, it's there.
Great. Let's see here. Okay. As a urologist that treats IC, patients too often blame all the pain on the bladder. It is imperative to address the symptoms and thinning related to menopause. The hyaluronic acid suppositories like the Reverie are estrogen free and are very helpful for those where estrogen is not desired. Everyone is different, but all issues must be addressed to get optimal relief. Great lecture.
Thank you. I completely agree with you. 100%.
Yeah, another person, all of this is great information, but ultimately finding the right doctor is so important. Is there a list of doctors that others have used who they feel really listened and with whom they had a great outcome? So I think that's something that would have to be discussed offline.
Yeah, and yeah, I usually refer to one of the national organizations for a list of providers.
Great. And then I thought this was a really nice comment. Thanks for a great presentation. 20 or 30 years ago, nobody gave talks on this, or it was only discussed briefly in hushed tones. So in this respect, things have improved. Let me get down to the bottom here.
And again, like I said, if you're seeing somebody that doesn't want to talk about it, or they make you feel embarrassed or uncomfortable, then that's not the right person to talk to. It's okay to go and look for somebody else. That's okay.
Yep. Great advice. Foria CBD suppositories and
that's it,
sex.
Foria. Yes.
Okay. The insurance companies are offering generic estrus, which is not good. What can we do to bring estrus back?
I mean, the only thing,
Sorry.
yeah.
Yep.
You can have your clinician write dispense as written for brand necessary. Yes, I do agree that a lot of times people can get more irritated from the commercial type of estradiol. We typically get our estradiol, even the estradiol for our patients, compounded in something completely hypoallergenic.
Can Reverie help with entry pain?
It's possible. A lot of times we use it in combination with something, some kind of topical at the opening. So a lot of these ones that go into the vagina, they help with more of the vaginal dryness. Sometimes the vulvar dryness, you actually need something right at the vulva.
Okay. And then it looks like our last one. Are there any oral vitamins or supplements that have been proven to help? Aloe, pills, D-Manose, etc.
Help with
that was
because so aloe, some people take aloe for their IC flares.
Mm-hmm.
D-Mano, some people take to help prevent UTIs. That I'm sorry, I just don't right now. Oh, bladder pain with and after sex. That would,
yep.
Sometimes, I mean, if you're taking aloe for IC flares and that helps, you can try that and see if it, if it does anything. D-Mano's probably not so much with pain. There's Azo over the counter, which is like half strength pyridium that some people, which isn't exactly oral vitamin or a supplement, but sometimes, it's not as strong as the pyridium. People prefer that.
Okay, thank you. Any more questions? It looks like we got to all of them in the chat. Anyone else raising their hand that I'm missing? I'm trying to monitor here. Okay, I think we got all the questions. So thank you so much for being here with us today, Jen.
Thank you for having me. It was great.
It was so informative. If you found this event to be of value, please consider joining us for future webinars and please share with your community. We are also excited to announce next month's webinar with Doctors Laura Santuri and Renee Hetzler. They will be presenting Don't Believe Everything You Read, How to Make Informed Decisions About Your Care. And watch your email for more information. So thank you so much for being here today.
Thank